very warm welcome also from my side. Thank you for the introduction, Florian. And happy to kick off our webinar series. So it's my pleasure to give a product overview of our cNeuro product today. And also for those of you who already know our solution, maybe we have some already existing users joining. I'm sure I will have something new for you as well to show. So imagine you could use only one solution for different disciplines, not only for radiologists, but also for neurologists and nuclear medicine physicians at the same time. And you could use those software for discussing complicated cases. And exactly this is one of the aspects that a lot of our users appreciate a lot about our software and what makes it very unique. So it's one platform with different modules that covers the entire patient pathway and that can provide useful information for those different disciplines. To be a bit more specific, I would like to show you our cNeuro product portfolio, which is a flexible cloud-based SaaS platform that can be integrated into the PACS system for optimal clinical workflow. It consists of 4 regulatory approved products. They are all CE marked and 510(k) approved, and SyMRI is additionally available in India. You can see here on the left side, we have SyMRI. This is our automated quantification solution where you can process 3D T1 and FLAIR images. You get volumetric outputs as well as automated lesion detection. And now with our most recent addition, SyMRI 3.0, you can additionally quantify additional markers, also from T2 star gradient echo images, where you can additionally detect microhemorrhages and superficial siderosis, as well as from the FLAIR sequence, lacunes and cortical infarcts. And if you use it for longitudinal monitoring, it's also possible to detect so-called ARIA, so amyloid-related imaging abnormalities from the new disease-modifying therapies that are now also approved in Europe. So this is brand new, and I'm happy to show you an example later. But let's first have a quick look also at the other products. So CDSI is particularly addressing neurologists. It's an AI-assisted clinical decision support tool where you can combine imaging data and clinical data, and it helps you with advanced dementia differential trend diagnosis, as well as prognosis estimation, whether a patient is, for example, about to develop Alzheimer's disease. And then we have CPET and CDAT, our 2 nuclear medicine products, which have been closely developed with our collaborators, GE Healthcare. And CPET is an automated FDG and amyloid PET brain quantification tool with which you can detect amyloid in the brain or also reduced metabolism from the FDG images. And finally, CDAT is measuring the loss of dopamine transporter neurons in the brain, which is relevant to detect Parkinson's disease. Maybe some of you know the product Cortex ID Suite or DAT-Quant from GE Healthcare. So basically CPET and CDAT are kind of the cloud-based evolution products of those two, developed by the same it's coming from the same person, let's say Lennart Turfjell, our previous CEO, who was involved in developing all those products. So this was a bit of an overview of the different products that I will present, let's say, in the next 15 minutes. But before I'm doing so, I would like to mention again that we have some of our esteemed users and KOLs in the field who will also talk a little bit more about the real-world clinical insights of using our products in their own clinics. So we have Professor Tobias Granberg from Karolinska University, who will talk about the clinical utility of SyMRI and CDSI in 2 weeks from now. And then we also have Professor Brendel from Ludwig Maximilians University, who will talk about CPET, so our nuclear medicine product. So make sure that you don't miss this unique opportunity to hear the insights from your peers. Before presenting the 4 products that I just mentioned in a little bit more detail, I also want to give a brief overview of the workflow, so how you can use cNeuro. And there are basically 2 options. Option 1 is really a 0-click workflow when you have a PACS integration in place. So what we basically do is we install a so-called cNeuro gateway. It's a virtual machine between your PACS system and the cloud software, or the cloud basically, which de-identifies all the data that you're sending from your PACS system before the data is being processed in the cloud. And with a specific secured mechanism, we can re-identify the data and send back the outputs in your PACS system. So you can get these PDF reports as well as the segmented images sent back to your PACS so that you don't have to leave your clinical workflow. And the second option is that, you don't need to have any installation at all. You can only process our images via our web viewer. So we can just create you an account there, and especially for a trial, this is very easy to use and test some first cases. In terms of what data you need, for SyMRI, you need a 3D T1 gradient echo image and a T2 FLAIR series, can be 3D or 2D depending on the application. And of course, as I mentioned before, if you want to use it for ARIA monitoring, then you need a T2 star gradient echo sequence as well. For CPET, you send FDG or AMOLED PET series, and for CDAT, you have DAT-spec images with the 123 IO flupen tracer. So that's the data we can process. So now let's have a bit of a closer look into our SyMRI product. I already mentioned before that we can quantify the brain volumes from lots of different regions in the brain, as you can see here on the right side. In total, it's 135 different regions. Of course, you don't always want to look at all those 135 of them, but we summarize the best of those regions for you in these disease-specific reports, so don't worry about that. In addition, from the T1 images, we can quantify the volume and the count of hypo intensities, as well as disease-specific imaging biomarkers, like, for example, the medial temporal lobe atrophy score, global cortical atrophy score, or also FACECA score, midbrain to pons ratio, callosal angle, to really help you differentiate between different diseases. From the FLAIR series, we can quantify the volume and count of hyperintensities, so lesions in the brain, mostly relevant for multiple sclerosis. And now with the most recent addition of SyMRI 3.0, we can also quantify cortical infarcts, lacunes, and for the longitudinal monitoring, also ARIA-E. From T2 star gradient echo images, we can quantify microhemorrhages and superficial siderosis, as well as the long-term monitoring of ARIA-H side effects. We not only compute the absolute volumes, but we always compare the data with a healthy control database of more than 10,000 people, and we can do the comparison both cross-sectionally, but then also longitudinally. Here you see an overview of our different reports. So we have a dementia report, our dementia differential trend report for CDSI, a patient report, which is a bit more simplified, Parkinson Plus report, multiple sclerosis for 1 and 2 time points, traumatic brain injury report, epilepsy, dedicated brain health report, atrophy and lesion reports, and the 2 new ARIA-E reports. The 20 minutes of today are not enough to cover all of those different reports, but I want to pick a few examples to show you how the solution works. So I've picked one dementia case that I would like to present, and you can see here an example of the full report that we are providing with patient information and the logo on the top, then some screenshots of the images, a quality check that we're always doing on every scan, and then the quantitative information. You see on top some volumetry information and then the disease-specific imaging biomarkers, and you already see that some of those values are appearing in red. That means that this individual patient value deviates a lot from our normative healthy database. So you see the percentiles here, and for example, the hippocampus is below the first percentile, meaning that only less than 1% of the healthy population in the background at the same age, same sex, and same brain size have such a small hippocampus volume. Then on the right side, you can see now always just the middle part of the report to make it a little bit bigger for you. You can see the simplified version for discussing the results with the patient. And then now our most recent addition, SyMRI 3.0, including those 4 new biomarkers. So this is how it looks like: lacunes, cortical infarcts, microhemorrhages, and superficial siderosis that we have now added to the dementia report, really serving for additional diagnostic purposes, but also for the monitoring of MR-based contraindications for the new therapies. Now, the patient here you see was eligible to receive the therapy, but now if we're looking at the longitudinal follow-up monitoring, you can see from the ARIA-H report that the patient developed 1 new microbleed as well as 1 new siderosis that you can also see here from the image, as well as also if you're looking at ARIA-E, the patient developed an edema here in the left occipital lobe. So yeah, based on these findings, and you can see they are very subtle here, so it was quite useful to use the software. And yeah, the patient was actually suspended from therapy based on this finding because of those mild side effects that were found by the tool. Another quick example I want to show is our multiple sclerosis solution, and you can see the cross-sectional report on the left, the longitudinal report on the right. You can see we can detect lesions, counts and volumes in the different areas of the brain, so periventricular, juxtacortical, deep white matter, and infratentorial. And then, of course, for the longitudinal monitoring part, it's mostly relevant whether a patient developed any new lesions that you can see marked in red, and then also illustrated here as plus 12 new lesions. You can also see the progression of the atrophy over time, so not only one time point, but then also whether the progression is abnormal or not. Here you can see how this can look like in the PACS system. So we not only provide the original FLAIR images, but we can also reconstruct the FLAIR images based on the ACPC line so that you can easily review the images as well as the difference map of the longitudinal monitoring. And you can easily see that this new lesion was picked up very nicely by the software. You can scroll through and then make sure that it aligns with the automated quantification results. For MS, this is especially important because, as you can see here from the study that we did, there's a huge variance or variability between different raters. So we have here included 7 neuroradiologists that have manually segmented the brain of multiple MS patients, and you can see that there are quite a lot of differences there. And the nice thing to see is that the consensus of those raters, very well matched with the results of our quantification software. So showing that it performs equally well as the consensus of trained neuroradiologists, and it also reduces or improves the consistency, let's say, between the readers in the end. So now I was talking quite a bit about SyMRI, but I, of course, also want to make sure that I include the other products we have. So let's have a look at CDSI, which, as I already said, is a AI-driven software for clinical decision support for memory disorders that can help, first of all, with differential dementia diagnosis, because it not only compares the results with a healthy control database, but also with patient data. It can also help to estimate the prognosis of a patient from developing from MCI to Alzheimer's disease, and it can provide decision support regarding deciding about the next diagnostic test. Here we've also published 2 studies together with our partners at VUMC in Amsterdam that showed that by using CDSI, we can basically reduce the number of lumbar punctures done to around 20-25% with the same diagnostic accuracy. So I think quite relevant findings here. And you can combine the imaging data with clinical data, so neuropsychological test data, CSF values, as well as genetic information, because in the end, the MRI is really just one piece of the whole puzzle. To look at a specific case, we have now here again a dementia report that has some mild atrophy in the brain, let's say in more frontal areas, but based on the CDSI report here, it's also not very clear if the patient now really has frontotemporal dementia or may still be cognitively normal. So again, here really comparing to a patient database in the background. And what I want to demonstrate here is to show how useful it can be to combine the MRI information with the clinical data that was provided here by the neurologist. So the neurologist entered all those information, and then in the end, the tool was able to give a more confident diagnosis with the probability of frontotemporal dementia here rising based on the combination of those different data sets. Then a few words about cPET. As I said, one of our nuclear medicine products that can help with automated amyloid and FDG PET quantification. It can support different tracers like florbetabin, florbetapir, and flutemetamol. We can process both PET-MR images, so when we have the real MRI of the patient available, as well as PET-CT images. There we are then taking an MR template from us to combine it with the PET image. And it has been proved to work very well also to use the PET-CT images. You're then able to change the reference region between pons, cerebellum, and cerebellar gray matter in case there are any artifacts in some of those regions. And in the end, you get SUVR scores, SET scores, and centiloids for the amyloid PET quantification out of it. So SUVR values are standard uptake value ratios that can quantify the ratio of the tracer uptake between the target region and the reference region, and the SET scores then provide a measure of how much the SUVR value deviates from a healthy database. This means that for amyloid PET, the higher the SET score, the more pathological, because more tracer uptake means more amyloid in the brain. And for FDG, it's the reverse. So lower uptake, meaning lower glucose metabolism in the brain. So again, more pathological findings. This is how an example can look like. So this is a typical FDG amyloid, not FDG Alzheimer case, where you see reduced uptake here in the parietal and temporal lobes, also indicated by the negative SET scores. And on the right side, you see a typical amyloid positive case with more uptake here in typical areas as well, and a centiloid score of 90, which based on the interpretation of centiloid values can be considered a positive case. One slide about the validation of cPET, because I think this clearly shows how well the automated quantification findings align with the consensus, again, of 5 trained readers. So we were comparing, again, the automated quantification outputs with the visual read, and we can see that both the PET-MR and PET-only pipeline showed around 99% agreement between the visual read and the quantification results, which I think is a very good finding to show that it's really matching between the two. I have 2 more slides on CDAT and then a summary slide, so we're almost at the end. So last but not least, CDAT is able to process DAT-SPECT images from the 123 IO-flupen tracer from GE. We can assess the loss of dopamine transporter neurons in the brain that can be associated with Parkinson's disease and dementia with Lewy bodies. We can report the striatal binding ratios of these areas in the brain that are the caudate, the putamen anterior, and the putamen posterior, and then compare whether this is normal, again, compared to a healthy reference database. As mentioned before, CDAT was developed very closely together with GE Healthcare and actually produces the same results as CDAT because it's based on the same code and the same reference data. Here you see an example of a positive Parkinson's disease case with reduced striatal binding ratios, especially in the posterior putamen, and also some left-right asymmetries. And here you can see on the right side, again, our most recent addition to CDAT. We can now also provide a second report page with the graphs where you can see how your patient or where your patient falls in comparison to the reference database. You can all configure this in the settings, and you can from now on also upload raw data, so it doesn't need to be pre-reconstructed as in our older version before. So if we're taking this all together, we can say that our different products can really support the entire dementia patient pathway. So if you're imagining a patient that has some symptoms, for example, goes and sees a neurologist or primary care physician, we have an additional non-medically approved tool called CCOG for cognitive testing that can be used, but then SyMRI mostly for seeing any structural deficits in the brain. If it's still not clear, the patient also can go on and see the nuclear medicine physician using CPET for automated quantification of FDG and amyloid PET. And then now, if you're thinking about the disease-modifying therapies, it's important that, again, the neurologist and the radiologist work closely together, for example, using SyMRI and CDSI to decide about the patient's eligibility and whether the patient can receive disease-modifying therapies or not. And then ultimately also for the side effect monitoring. So if we take everything together, we can say that cNeuro really provides a comprehensive neuroimaging AI suite with those 4 products that I just presented. We can automatically produce biomarkers such as brain volumes, lesions, disease-specific markers, centiloids, as well as striatal binding ratios. We can combine this imaging data also with clinical data for really helping with clinical decision support. And given that it's a cloud-based solution, it can be easily embedded in the clinical workflow, and it also allows us to produce updates on a regular basis. As you can see from the slides, we have a few more recent additions that are presented today. So and with this, I would really like to thank you very much for your attention. I'm happy to take any questions at the end. But now I would like to hand over to my colleague, Erik Lange, who will present on our SyMRI product. So Erik, the stage is yours. I will now stop sharing my screen so that you can share yours.
Excellent, Elena.
Now I'm back.
Thank you very much. Great overview. Can you see my screen?
Yes, we can see the full screen.
Perfect. Thank you, Elena, and thank you everyone for joining. So what if there was a way for you to decrease scan time in certain clinical protocols and scenarios, potentially freeing up precious time in your scanners, while at the same time getting access to quantitative data, useful both in your clinical practice, not just seeing more, but actually be able to measure and a way to become more objective in your reporting, but also useful for your future research, both for you or for your clinicians. This is what SyMRI is all about. And my name is Erik Lange, and I'm the product manager at Synthetic MR. And in the next sort of 20 minutes, I will show you 3 things. Firstly, I will briefly describe what SyMRI is. Secondly, we will look at the different outputs that SyMRI can provide. And lastly, I will briefly show 3 different areas where this can be applied in your clinics today, hopefully giving you some ideas on where this can be relevant for you and your colleagues. So SyMRI represents a new approach to MRI, one that moves beyond traditional contrast-weighted images. Instead of running multiple sequences for different image contrasts, SyMRI starts with one single fast quantitative acquisition, typically completed in just a few minutes. From that one scan, we can generate objective tissue measurements like T1 and T2 relaxation time and proton density, and then use those values to create almost any contrast you need. What this means in practice is simple. This means fewer scans, faster exams, and consistent image quality. So you can produce both standard and advanced contrast all from that same data. And at the same time, SyMRI unlocks the power of quantitative MRI, getting you access to quantitative maps, automatic tissue segmentation, age-matched reference curves, and the ability to track these changes over time. So this isn't just faster MRI, it's also MRI that's measurable, reproducible, and designed to support more confident clinical decisions. The outputs can be categorized into 4 categories. We have the contrast-weighted images like your standard 3D T1 and 3D T2 images, and more advanced images like double inversion recovery images or phase-sensitive inversion recovery images. You can use these to replace some of your conventional images, thereby decreasing total scan time. Then we have the quantitative maps, like the T1 and T2 relaxation time and proton density, or their inverse, the R1 and R2 map. And these represent the absolute tissue properties of the brain in terms of relaxation time. So every voxel has a number attached to it in milliseconds that can be measured and will be very similar across scanners and field strengths. Third, we have the segmentation maps based on the quantitative data, white matter segmentation, gray matter segmentation, CSF, and of course, very importantly, the myelin correlated segmentation. So you can accurately quantify myelin in as fast as a 3-minute scan. Then we have the reference curves that will help you compare the patient values compared to an age-matched healthy population, and of course also against the patient itself over time. The results are typically automatically summarized into reports that are together with the images available in your packs. Scan time, of course, varies a little bit between MRI machines, field strengths, and settings used. But if you have access to AI acceleration techniques like on Philips SmartSpeed, you can come down to as little as 3 minutes with a 1.2 millimeter isotropic resolution. And then that's without any really manual processing needed. We've had SyMRI in 2D available for some time, and this is still an excellent sequence which provides great in-plane resolution, and in certain scenarios this is what many customers prefer to use, but it has slightly thicker slices and a small slice gap. So since last year we also have a 3D version available, the key difference of course being isotropic imaging and no slice gap, allowing you to reformat images into axial, coronal, or sagittally. So this provides a very neuro-relevant form factor with whole brain coverage for modern MRI workflows. So let's now look at 3 different examples of how SyMRI can be implemented into your clinical practice today. I'll start with pediatrics, and then we'll look at white matter disorders, and lastly, oncology. So in pediatrics, that everything starts, of course, with that fast 3 to 5 minute scan time, which you use to replace typically your T1 weighted and T2 weighted images. This then gives you access to having the myelin maps for objective myelination of the maturing brain, and head size and brain size in having that in the reference curves and directly in your packs really helps in the confidence for the radiologist. CSF measurements are great to have for patients with hydrocephalus or for shunt follow-up. And of course, all of this quantitative data is provided to you without any additional scan time implemented this way. So let's first talk briefly about myelin, and truly objective assessment of myelination is very difficult or almost impossible using conventional images, especially if you're not a super expert in pediatric neuroradiology. You would of course look at patterns in signal intensity in T1 and T2 weighted images, and then compare those with the patient age. But with SyMRI cNeuro, this becomes much easier, as you will have a number of total myelin volume compared to a healthy reference population that you can track longitudinally over time. So this is, for example, great when assessing patients with potential developmental delays. Another example of how quantitative data can help you in pediatrics can be seen in this patient. The patient is displaying with typical developmental patterns, but representing with macrocephaly, meaning that the head is larger than normal, alongside a documented foramen magnum stenosis and enlarged ventricles. As you can see, the imaging results here indicate a subjective stability over a 5-month period, so we can't really see whether anything has changed by just looking at the images. But actually, in this patient, the CSF had increased by 16% in those 5 months. And at the same time, as can be seen on the left, the brain is shrinking, which is not something that we want to see in a patient this age. So the decision here in this example for surgical intervention was supported by the quantitative data, and the neurosurgeons considered the SyMRI calculations as a key part in the broader set of data points on the necessity for the necessity and timing of intervention. When you will read these cases, you will have access to these longitudinal reports in your packs, so you can very easily see the trend of the patient and report on the differences compared to the most recent exam. If your packs and reporting tools allows it, you can even auto-populate the radiology reports with the actual numbers, saving you as a radiologist precious reporting time. But you don't have to trust me here on the value of SyMRI in pediatrics. Instead, I recommend you to sign up to the next webinar in this series, because on the 5th of May here, Dr. Victor Schmidbauer will share some of his experiences and expertise within quantitative MRI. And Dr. Schmidbauer works at AKH in Vienna and have published several important articles on synthetic MRI, especially in the pediatric field. So I'm very happy to have him visit our webinar next week. Make sure to sign up for that one. Okay, moving on to white matter disorders, and for example, MS. The quantitative data access to that quantitative data in as fast as a 3-minute scan time is very useful. And then in MS, of course, we want to track whole brain atrophy over time. SyMRI also provides the addition of the double inversion recovery images, which have shown to provide increased lesion visibility. Using SyMRI, you get access to that sequence at no extra scan time. And then for the more advanced users, the ability to implement myelin imaging for more advanced disease characterization. As many of you probably know, BPF, or brain parenchymal fraction, is a very simple and effective measurement of whole brain atrophy. It was recommended back in 2020 in the Magnum's consensus guideline to measure global brain volume, since this is associated with and predicts disability also in very early stages of MS. And with SyMRI, you can have very fast and easy access to that BPF measurement and provide it to your neurologist without any additional user input needed or cloud processing. And then next up is myelin imaging, and here we have an MS patient with several white matter hyperintensities. We can all clearly see the lesions, but the hyperintensities all look the same, right? Today, typically, you would report on the number of hyperintensities, any new lesions, or potentially total lesion load if you have a tool like SyMRI, which Elena just presented. With SyMRI, you can take this one step further by characterizing also the severity of the demyelinization. When we look at the myelin map here, we can clearly see the difference in severity in those 3 lesions, going from mild to moderate to severe or almost complete demyelination. I don't have that much time left, so I will move over to the last area, the third area that I briefly want to mention. And this is an area where we've seen a big increase in interest thanks to the 3D version of SyMRI cNeuro. This is within oncology. In this area, SyMRI cNeuro is often used to characterize the tumor and tumor content using the T1, T2, and PD map. And this can provide a lot of additional information and confidence to the oncologist or surgeons beyond size alterations or contrast enhancements. One example is this one. This is from a study published by Dr. Kikuchi in Neuroradiology in 2024. In this example, we can see the T2 flare mismatch sign. If you're familiar with this imaging biomarker, then you know that this has a very high specificity for astrocytoma, meaning that if you see this imaging sign, you can be certain that it is an astrocytoma. However, it is still a subjective imaging marker with a fairly large inter-reader variability. But what happens if you don't see the T2 flare mismatch sign, as in this patient. Could still be an astrocytoma. We don't know, because but could also be something else. And this is where the quantitative maps come in. As we can clearly see in these images, the T1 and T2 relaxation times from the SyMRI, the content of the tumors is completely different. In the astrocytoma, we have long T1 and T2 relaxation time indicated by the red here in the images. And in the second case, the relaxation time is much shorter, indicated by the green. Also now, thanks to the quantitative data, we have the ability to evaluate this data numerically, providing an inherent objectivity. And this is exactly what they did in this study, is that they found that if you put a cutoff value at 2,100 milliseconds in for T1 and 99 milliseconds for T2, can actually increase sensitivity up to 94% for correct identification of astrocytoma versus the glioma, while still keeping 100% specificity. And the reason why this matters is, of course, treatment. While they share the same, these tumors share the same IDH mutation, their prognosis and treatment differs. And so the glioma typically responds very well to chemotherapy, while the astrocytoma require more intensive treatment or surgery. And being able to correctly diagnose the patients with the correct tumor as early as possible is, of course, key for these patients. Then lastly, just an example of implementation into your MRI protocol, what it could look like. Of course, it will differ a lot between different hospitals and for different clinical applications, but I took an example here from Ben Kennedy at Mermaid Beach, who presented on SyMRI last year at ECR. And as you can see here, they have a fairly substantial brain protocol, just about 20 minutes, both T1, T2, and flared up diffusion weighted images, MRA and SWI. And what you could do, of course, is by just replacing the 3D T1 and T2 weighted images, you can reduce scan time in this protocol down to 17 minutes instead, while at the same time getting access to all of the images, segmentations, and quantitative data in a very, very efficient way. Of course, you don't send all of this data to PACS all of the time, but you will customize the output based on your need. And it's good to know that all of this data exists and can be made available, giving you a really rich data sets for future needs or for novel group level research. That is a few examples on how SyMRI can be valuable in your clinical practice today. I don't have time to go much more in depth today, but if you want to know more, we have several use cases available on our website, and our team will be happy to set up a more in-depth demo for you. Lastly, a quick mention on the implementation. In modern hospitals, the implementation is setup is very straightforward. So SyMRI is an on-premise solution, meaning that the software is installed typically on a server in your hospital, and no images or patient data need to leave the hospital network. We call our workflow engine SyConnect, and this basically runs SyMRI according to pre-configured rules, providing you a lot of flexibility, allowing you to have different outputs for different patients or protocols, all in a very sort of efficient manner without any manual interaction required. And lastly, thanks to the merger between synthetic MRI and combognostic, we also now have a new packaging which we call SyMRI cNeuro Plus. This allows actually for an on-premise solution of SyMRI that Elena just described, giving you access to the state-of-the-art brain parcellation and lesion segmentation and most of the clinical reports that SyMRI can provide. And this can be a great option for hospitals that still don't allow cloud deployments, and something we see a big need for in certain countries in Europe and Asia, for example. So just to summarize on the SyMRI part, giving you access to both quantitative data and clinical efficiency in one simple solution, both standard and advanced images. It can help you increase MR throughput, increasing objectivity in your MS pediatric or oncology workflow, and it's an on-premise solution with full automation into your PACS. And with that, I thank you for listening to this part of the presentation, and I hand back over to Florian.
Awesome. Thank you both for your great presentations. I'm going to steal the screen from you. Okay, so you should be now seeing my screen again, which is just what I mentioned in the beginning, that we now have time for some questions and answers. So there are some questions, and I'm going to ask them. So for the audience, and as said, we're going to put all of them into a Q&A document, going to send that out as well. So first question, which goes to both of you, maybe, because it was just mentioned a couple of minutes ago from Erik as well. So that, Erik, you mentioned that the outputs can be customized, which are going to be sent back to the PACS. So that's going to answer one of the questions. So is it possible to choose what outputs to receive in PACS? So maybe, Erik, as you just described it, you can go first.
Absolutely. So a typical setup with SyMRI improves multiple protocols, and you can absolutely set up rules in SyConnect on what kind of outputs you want to provide. So for example, in an MS patients, we may want to have the T1, T2 double inversion and phase-sensitive inversion, but we might not care for the CSF map, for example. And then we want to have the longitudinal report. That's a typical example. But in, for example, pediatrics, we do want to have the CSF map if we're talking about a potential hydrocephalus case. So you can absolutely have different outputs for different clinical scenarios.
Thank you. And Elena, how does that look like with SyMRI?
Yeah, very similar, I would say. So you can also configure the outputs on what you want to receive back to your PACS. I think especially for SyMRI, this is very important. You saw all the different reports that we can generate. And of course, you don't want to have all these different reports for every single clinical case in your PACS. I mean, if you're, for example, investigating or you're following up with a multiple sclerosis patient, you don't want to see the dementia report in PACS to not confuse the patient, to not confuse the referring neurologist. So yeah, I would say probably 80–90% of our users have a specific workflow set up where they decide upfront based on, for example, the protocol they are running, what reports they want to have sent back. This can also be fully automated. So if you tell us the series description is MRI brain dementia, and for this certain protocol, I only want to receive back the dementia and the Parkinson report. This is, for example, something that we can send back and then configure everything for you. So yeah, very easy, can all be configured based on the individual wishes. And yeah.
Okay. Thank you.
I could just mention also that it's also possible to have multiple outputs sent to multiple locations. We have some customers that are both in clinical and in research, and sometimes they have a research PACS set up, so or a clinic and a research and a clinical PACS, so we can send one set of outputs for this sort of clinical routine imaging and another set of outputs to a research PACS if you're conducting a research study and don't want that in your clinical PACS.
Yeah, very good addition, Erik. And I also have one more thing that I would like to add, because we have our, as I mentioned before, we have our cNeuro web viewer. So what you can do on the cNeuro side as well is you can have specific reports that you always want to have sent back, but then you could decide on an individual basis if, for example, now this MS patient that you're investigating, you get back the MS reports, but you see some atrophy in the patient where you might think, this could also go into a dementia direction. Then we still produce all the reports and you can log into our web viewer, click one button and then additionally send this, for example, additional dementia report back to PACS. So this is another way of kind of working to make sure you only receive what you need in PACS, but you then still have the possibility to check all the other reports in the web viewer.
Perfect. So thank you both. So just a matter of time. So another question which came in is, I think it goes to you, Elena, most likely, because it came in once you presented the healthy control. So how is the healthy normative comparison database comprised?
Yeah, very important question. I mean, of course, all the results that we're providing, especially the percentiles later on, are of course based on whatever data we have included in our normative database. So very, very good question. I can mention a few things on what is included there. So it's a very large database, as I said before, more than 10,000 healthy controls, also coming from different sources, let's say. So it's 21 different projects or different sites involved there. It's both publicly available data, but also some data from our collaborators. And we have made sure to really check this data carefully and make sure that we really only include healthy controls there. So there are no, let's say, patients included with any major neurological disorders, no incidental findings that could influence the results. So really healthy cases. It's all based on adult data, so between 18 and 94 years. Pretty well aligned in terms of sex, so female and male pretty equally distributed. And I hope that answers the question. Otherwise, if this person has some follow-up questions, either text again in the Q&A or happy to take that question also later, maybe in a demo.
Exactly. Thank you. So another question, which might is interesting for everyone to know, is if a department is starting with the quantitative imaging, so how much extra time does the post-processing typically add to the reporting workflow? Maybe Elena, you can go first.
Yeah, to the reporting workflow. Okay, I see. Yeah, I mean, of course, every time you're introducing a new solution, I think everybody wants to make sure that the solution works to satisfy your own needs, basically. So, of course, in the very beginning, it could take another 1-2 minutes extra, let's say, to review the outputs. But really, the goal is to not increase the reporting time, but really to shorten it. And that's what we see if our users are kind of settled up with using the software. We clearly see reductions in the usage time of the reporting. First of all, of course, on the diagnostic side, because if you, for example, have the tool automatically detect all the MS lesions for you and you don't need to kind of review or kind of manually count all of them, that definitely shortens the reporting time in the end. And maybe one thing I can also mention here is not only the time on the diagnostic side gets reduced, but also the time on the reporting side, because now, again, one of our most recent additions that I haven't mentioned before is that we now for SyMRI also have a structured report that we can produce. So you get all the information from the PDF reports also in a structured format, and you can then implement this in your hospital IT setup system, basically, for example, with PowerScribe or Epic, so that you get those values automatically transferred into your medical report. Means that you don't have to copy and paste those values, and it additionally saves time on the reporting side. So I would say, to kind of answer the question, in the end, it's not adding up to the reporting time, but it's actually reducing the reporting time. That's what we have seen from many of our customers, and there have also been some studies published on that it reduces the time used per patient. Maybe Erik also has some additional comments there. How does it look like on the SyMRI side? What do you think, Erik?
Yeah, that's good. I'll make the question slightly larger. The question was sort of phrased for the reporting time, but maybe I can give an overview from the SyMRI side. As I mentioned, we first have the fast scan, which can reduce sort of the acquisition time. Then this data needs to be sent, just like any other images, to your PACS, and then from PACS to SyConnect and be processed, and then come back. And then we have sort of the actual reporting. The processing time, since the question was so post-processing time of SyMRI is really quick. A typical 2D case maybe takes 30 seconds to process, maybe even less. A big 3D case, half a minute to a minute. And then things that we can control is sort of transfer time from PACS to SyConnect. But typically, you have the outputs available just within a few minutes of it being sent from the PACS. And then regarding sort of reporting time in modern PACS and reporting tools, you would tie the sort of DICOM SR into your reporting template so that it can auto-populate, and then you really don't have any time at all to spend on the reporting. What you, of course, need to do is review the images and the segmentation maps, that they are correct and that you can understand them. But then really, if you have that set up, reporting time is super simple. If you don't have that possibility, you would still have the longitudinal reports in your PACS, and then you would have to manually type or dictate sort of dictate your answer into your reporting template, just like you normally would. You would dictate the numbers from the report instead.
Thank you. Maybe to just make sure that we end the webinar on time, maybe a quick answer on another question, which is what is the most valued feature of our technologies, Erik?
Good question. That depends, of course, a lot on your user profile. But I think for SyMRI, we have a lot of customers sort of in the academic medical hospitals that have sort of one foot in the clinical world and one foot in research. And the ability to use the quantitative data, both for clinical practice and for really advanced research, is probably sort of one of our key customers or customer needs or values that we provide, if you're that kind of customer.
Anything from your side, Lena? What's the most valued feature of?
Yeah, I would say, again, as Erik said, depends a little bit on the type of the customer, but I would clearly say, I mean, the longitudinal follow-up of lesions for multiple sclerosis, that you don't need to kind of do the tedious work of counting the lesions. That's definitely one feature that a lot of our users appreciate a lot. And then maybe in the dementia spectrum, really, that we go beyond just volumetric quantification, but we provide all those disease-specific imaging biomarkers that can not only tell you that something is abnormal or normal, but can really help you to decide what kind of condition it is. And then on CPET, I would say the centiloids, because it's really a standardized measure that is now used widely also for clinical trials to decide about patient eligibility for the new therapy, but then also for deciding about whether the treatment can be stopped. So I would say those three features are kind of the most valued, out of the different things we provide.
Perfect. Thank you both. Just a matter of time that we have 1 minute left, so we can make it on time before we end the webinar. I would like to thank you both for your presentation, and I would like to highlight one more thing, which was quickly shown by Erik as well, that you know that this is going to be a webinar series. So meaning we just kicked it off, it doesn't end here. So next week, Tuesday at 2 p.m. European Central Time. So we have the session with Dr. Schmidt-Bauer from AKH Vienna, which is giving his clinical insights about SyMRI. So we hope that we can actually see you there again. It is the same registration link as you registered for this webinar. So if you haven't registered for the other one, please go ahead and register for the other one. And we have the 2 other upcoming as well. So it's from now on each week. So each Tuesday, there is one webinar coming up for until the May 19th. So with that said, I would like to thank you everyone to attend the webinar, thank the presenters, and wish you a pleasant rest of the day. Thank you, everyone. Bye-bye.
Thank you.
Thank you very much. Bye, everyone.